Okay. So it's now 8:30, and if everybody's ready, we'll go ahead and get started. So I'd like to welcome everybody to our El Paso County Board of Health Board of Directors, or Public Health Board of Directors meeting. And our first agenda item will just be roll call. So obviously I'm present. Vice President Doris Ralston is excused. She's on vacation, having fun. Commissioner Geithner? Here. Commissioner Nelson?
Here.
Mayor Todd Dixon?
Here.
Hunter Barnett?
Here.
Dr. Chan? So I don't see her online, but we'll wait and see if she appears. Courtney Salt?
Here.
And Dr. Vu?
I'm here.
Okay, good morning, Dr. Vu. And just so you know, in this room, I can't, I've tried to text you before, and it doesn't make it out of here, so I won't be able to do that, or I won't receive yours either, I don't think. So, okay, but good morning to you. And with that, item number 2 is the approval of the agenda, and I would ask for a motion and a second to approve the agenda.
Mayor Dixon, I'll move to approve the agenda.
Okay, thank you, Mayor Dixon.
I'll second.
Okay, thank you, Hunter Barnett. All those in favor, please say aye.
Aye.
Okay, any opposed?
Aye.
Thank you, Dr. Vu. So that passes unanimously. And next we'll move on to item number 3, which is Board of Health comments. So any board members with comments? Commissioner Geithner.
I'll make this quick, but it's been in the news for a while, but I wanted to bring up, because I had previously brought up that I thought that we should support our state moving to eliminating certain things from SNAP benefits, and that was something that we were looking at doing, pushing for at the county. And surprise, apparently the governor submitted a waiver to Secretary Rollins, unbeknownst, I think, to anybody in the state. It was a big surprise, and that came out in the news, so that has already happened, though I think we asked for one of the most limited waivers, so there's probably a few other things that we could waive out of too, so I don't think that that is something that we should definitely not pursue. I think we should look at some of those extra things and think about, supporting and trying to ask our state to do that in the interest of all of our residents and health and the entire system. But just wanted to kind of give an update that was kind of a cool thing to see, is that we actually did see those sugary drinks removed from the SNAP benefits.
Okay, thank you for that. And I don't see your hand up or anything, Dr. Vu, so I'll take it that there's nothing online. Commissioner Nelson.
I just wanted to say hello to everyone and introduce myself, because this is the first meeting I've been able to attend in person. I was appointed to the commission seat for District 5 in June, and then at the end of July, the commissioners all came together and decided which boards and committees would be divvied out to help, that I would help take on, because they had quite a workload. And so I have replaced Corey Applegate on this Board of Health, and I look forward to just the work and furthering health in our community. And I have been participating in the executive sessions, but as far as a public open meeting, this is the first one I've been able to attend. So just want to take a second to explain who I am and why I'm here all of a sudden. Thanks.
And thank you for doing that, Lauren. I meant to actually ask board members to do that. I believe, Mayor Dixon, this is your real first regular meeting, is that right?
That's correct. This is my real first meeting. My name is Todd Dixon. I'm Mayor of Green Mountain Falls, recently appointed as well. My background is actually in aviation, and 23 years with the Federal Aviation Administration and Learjet before that, Boeing before that. Retired from aviation and got pulled into Planning Commission in Green Mountain Falls, and now I'm mayor. Second term, so.
And Mayor Dixon's dedicates a lot of his time to public service. He also serves on PPACG and
PPRTA.
Serves on PPRTA and other boards and commissions. So I think we're lucky to have him over here also. And Courtney, is this your first regular one?
I guess so.
Okay. Would you like to just introduce yourself?
I'm Courtney Salt. I am
member just from the community at large. And I'm a mom, and I love El Paso County, and I'm happy to serve.
No. And so it was unusual because when the new board members came on, we had some special meetings and things, which were their first meetings. One was for a contract and some other stuff. So it kind of like they've gotten tossed into the fire without the normal regular meetings first. So thank you for doing that. Anyone else with any comments? Then I would just say
Dave,
that.
could I just put
Yes.
Lauren on the
Yes.
spot, sorry, Commissioner Nelson, on the spot a bit, because she didn't introduce what her background is, but I think it's interesting and a part of the great contribution to this, so if we could let her.
Sure, thanks. So I have a degree in food science and nutrition with a focus on food safety, and I worked for several years in product development as a food scientist in food manufacturing, and it was a great job. I loved it, but just ensuring that the products we were putting out to the market weren't going to make people sick was part of the job, and that quality assurance, So very familiar with foodborne illness, and then I have been serving on the Colorado Springs District 11 School Board for the last several years. So I also now have learned a lot about education and just helping. I think a big part of health is just making sure people understand how they can make choices that will take care of their bodies. And so education and that world is also something I think I can help bring to this group. Thank you for that opportunity.
Okay, thank you for that. And finally, I'll just say that yesterday on City Council, we had two resolutions of appreciation for folks who had worked with the city. One was a woman who'd been with the police department as a civilian, working in different departments for 36 years. And the other was a gentleman who had been with the Parks Department with really the community centers for 30 years. And they both spoke about, really they thanked us for letting them be part of serving their fellow citizens for that time. And I want to thank all of you that are here today that work here in public health, because you're really on that same journey. And I think Deanne's been with us for a decade or so, and so maybe she has 26 more years left in her to match that 36 years. And that lady was very happy person. So it's real impressive to see that kind of dedication and longevity. So thank you for your work here. And thank you to the new board members. And so with that, we will move on to item number 4, which is approval of the minutes. It's for a couple of different meetings. And is there a motion and a second to approve the minutes unless there are any corrections?
Deborah Chan, I'll move to approve minutes.
Thank you, Dr. Chan.
Mayor Dixon, I'll second.
All right, thank you, Mayor Dixon. With that, all those in favor, please say aye.
Aye.
Any opposed? Okay. Thank you, Dr. Vu, and so that also passes unanimously. And next, we'll move on to public comment. And I believe we may have someone today for public comment. Is that correct? Okay, I'll go ahead and let me see if there's a little statement here to read. And it's at the end, but we have 3 minutes, right? Do we have a timer that we run? Okay, all right, ma'am, why don't you come on up and...
Okay, start the timer.
No, not yet. We won't do that, but we ask you to introduce yourself and
Okay.
then go ahead.
I'm Donna Rook. I'm here to commend you and offer a few suggestions on your strategic plan. My background is in the health space, is IBM sales and management, from punch card billing at CU Medical to first line manager in Minneapolis when they did DRGs in the hospitals, branch manager in Chicago when they did patient records. In my later life, I did reengineering and strategic planning at the Blue Cross Association, the mothership in Chicago, Moore Medical, which was a nationwide wholesaler, and the City of Chicago Department of Revenue. I had a great conversation with Michelle earlier this week about your strategic plan and your plans. I have two suggestions. One of them is to add civil defense. It's no secret Colorado Springs is in the bullseye of probably many missile maps, as well as you could put up a balloon, put off an EMP pulse, and shut down the city. So that's one suggestion. And I have some resources that I'm willing to pass along to Michelle. One of them is a little card you can carry in your wallet, has little dots, and it'll show up if you have problems. Also, you can write this down. There's an organization called Doctors for Disaster Preparedness that I belong to. Look on their website. On the right, there's just tons of information about civil defense. You can build a home shelter. You can survive unless it hits you directly in the head. You can build a shelter with tables and boxes and whatever. I suspect this piece you'd be working with emergency suppliers resources as well. So I'll pass along these resources as well as a book written by Art Robinson. He is the guy who did Vitamin C with Linus Pauling. He wrote the first U.S. Civil Defense Plan. The book is a little bit dated, but there's nothing really new, so I'll pass that along as well. Along with that, my second recommendation is to conduct a customer survey, and you find out what you're doing well and what you might want to look at. Both are good things to know, and you could look at civic groups, YMCA, health clubs, parent organizations, political, whatever. There are just a lot of people that I think could provide valuable input on how you're doing. My calendar is pretty full, but I will volunteer some pro bono time. I've talked to Michelle about that. So I don't have a lot of time, but if I can help with any of these things, I'd be glad to do that. Questions, comments?
Are there any questions or comments from board members? So, well, I want to thank you for coming in today and sharing that with us. Okay. And Amanda, are there any other folks signed up for public comment or online?
Comment.
Okay. Okay. Well, thank you again. Sure.
Since I'm new here and I've served on several other boards and committees, do we normally respond to public comment? Because other places that I've served, it's not been the practice of the board to respond or ask questions of a public comment. So I just want to make sure I understand procedure on this board.
Yeah. Since I've taken over as chair, I don't think we've had anyone with public comment. But if a board member wanted to ask a question, I would allow it. Yeah.
Okay. All right. Thank you.
Okay, and so we'll now move on to item number 6, and that is finance and budget. And Lauren Mearmont is going to go over June and July financial summaries. Good morning, Lauren.
Hi, Lauren Mearmont, Budget Manager for Public Health. And since we're doing introductions, I'm a CPA. I have a master's in accounting, and I've been working in government finance and accounting for more than a decade with a lot of grant management experience. But I've been here since February. So I just want to go over a little bit of the way that the information is presented for the financials for the board. I think there is a slide. Thank you. So just for to go over the way this information is presented on a monthly basis, the originally adopted budget is the preliminary budget that's adopted by the board at the end of each calendar year. That is in the column 3 from the right that says OAB. So that's the originally adopted budget. The column to the right of that says changes, and that's any resolutions adopted throughout the year would be reflected in that column. And then the last column that says revised budget is what we're currently working with. So that's our annual budget. Then going back to the first column, that is actually trended information. I just like to point that out. It's kind of a snapshot in time of where we are in comparison to prior years. So it's informative, but not like our actual current budget information. And then actuals is where we actually are for the year, and this is cumulative to date. So just wanted to provide that explanation. And then I'll go through the trends here, and then if anybody has questions throughout that presentation or at the end, happy to address those. So the first row is El Paso County funding that comes to public health, and that is allocated on a monthly basis. So we should always kind of be on target for budget with that for the year. So you see a $0 variance for that funding source. Similarly, state LPHA funding is a state allocation to us from CDPHE. It's an annual amount, and it comes in regularly through the year. So there's no variance there. For program-specific grants, that is generally our reimbursable grants. So we expend the money and then submit for reimbursement, and then that is a revenue source recognized as funds are expended. And so that does show a variance for June. If you look at that in comparison to our actual budget, we are exceeding our expected budget for the year for that revenue source. And we're just doing a really good job of managing our grant management and reimbursements for that. So that is trending in a positive direction. Licenses, fees, and permits encompasses all of our fee revenue for the department. So that's environmental health and immunizations, different programs that we offer fee for services for. And those are coming in higher than budgeted for the year because of improved processes and increased fees for services in certain areas. Medicaid fees and insurance is what it sounds like, and we are on track with our billing for that compared to our budget for the year. Interest income is based on our cash and investments in our bank account and the current interest rate, and that is coming in under what we had projected it to be for the year, but it's in line with the current market conditions. And then our contributions, donations, and miscellaneous revenue is just kind of ad hoc, like mini grants we might get, or just miscellaneous revenue. So it's not consistent. And then I'll just move on to expenditures. And I'll just say that I'm going to go through July in a similar manner, but it's cumulative, so maybe not as much detail in the presentation. So our personnel expenditures are trending in line with our budget. We actually expect that to come in under budget for the year. Same thing with operating. I don't really have anything to expand on there, but if anybody has questions, please let me know. And then for our capital expenditures budget, we've concluded our project related to that for the year, so there won't be any more capital expenditures for 2025.
Okay, Lauren, that was pretty clear as you explained it. Are there any questions from board members before she goes on to July on that?
An ignorance
Yes,
question here.
Mayor Dixon, go ahead.
Our fiscal year is a calendar year, or is it a different fiscal year?
It's calendar year.
Calendar year, okay, thank you. And do you have something that would show reserves?
So I do have information on our fund balance. It's not usually presented here, but I can go over that.
Can you maybe just follow up with an email with
Sure.
fund balance to the board? Yeah.
Sure. Yeah, and we can provide the fund balance policy and all of that. Okay.
Okay. Go ahead,
So
Commissioner Nelson.
am I to understand that that further left column that says budget is what the board originally adopted, say, last fall, and then the revised budget, you all came back and made
So
these
the
changes?
far left column is what I would like to title it trended budget. My understanding is this is how this information's always been presented, but no, that's like, it pulls in our originally adopted budget, but then also compares where we are at in the current year to prior year trends for like an analysis of where we should be at. But so the column that says OAB is originally adopted budget. And I'm open to suggestions on ways to improve this presentation too.
So then when you say a revised budget, what was the timing that you came and updated? When did that happen? Is it like
So-
mid-year points?
Yeah, so ongoing through the year, if there's a resolution to appropriate additional expenditures or revenue, then that would get reflected in the changes column. So we had one grant adopted, I think, in July, and that's reflected in the changes here. And then the most recent revision that was adopted in August has not been reflected here because that was booked in the system in August. So August financials will reflect an updated amount for that new grant.
Okay, so it's sort of an ongoing process, not a specific like mid-year truing up the dollars and.
Correct.
Okay, all right, thank you.
Quick question.
Yes, go ahead, Hunter.
On similar lines, do you have a view that is actuals to date plus forecast for the full year? Because this is all through July.
Yes, I do have that information. It typically hasn't been presented here, but we have ongoing conversations about those projections and anticipated.
I would actually like to include that here.
Okay.
In my work, it's this view plus what's the latest. I think the next one is 8+4. So we're a month or so out from that view, but I think you know what it is, right? It's simply year-to-date actuals, and then everything we know as of today. What does the rest of the year look like to then get to the full picture? I think that would be helpful and a great kind of complete view with this view,
Okay. Can do that.
if that's okay.
I'm fine with that. And everybody else good? And we learned, you can kind of project that by looking at the first column, which really carries us up to today or whatever month we're looking at. And then if we're over collected on grants, that's kind of good news. Looks like we're heading in the right direction for the rest of the year. If we're a little bit low on interest income, then maybe at the end of the year, we're going to be low by 60,000, or it's going to be a little more because there's going to be 4 more months and we're probably going to be a little low on interest on those. But I think yours is a more precise reading of it. So do you see that as a good idea also?
Yeah, that seems reasonable.
Okay. Very good.
I
Yes.
just want to make a comment, and I don't know if the rest of the board would agree with me, but if you feel like you would like to update titles for more clarity, by all means, like just because we've been doing it a certain way, if there's confusion, let's make changes. So please use your wisdom on helping bring clarity.
Thank you.
Okay, Lauren, I think we're ready to move.
I have a question.
Dr. Chan.
Regarding the program-specific grants, because there's no projected budget, it's hard to tell whether the changes are an aberration that might be for 1 or 2 months versus something that you could project to carry on for the rest of the year. So could you speak a little bit more about the program-specific grants and how we were able to arrive at a variance of $500,000, what accounts for that, and whether you project that trend to continue or whether it's a one-time thing?
I'll speak to what I can. So some of it is related to the timing regarding our calendar year budget for the county versus like a fiscal year contract period for a grant that might be July 1 to June 30. And for budgeting purposes, we tend to smooth that out and capture that throughout the year, but expenditures for that may vary depending on the scope of work. So we might expect that we would spend in one calendar year, but we really spend in another. And so it's still within the contract amount, but just the timing of recognizing the revenue related to when we spend it may vary. And so I think for a couple of our grants, we ended up spending more in 2025 where we had expected to spend more in 2024. But I'd be happy to dive into that and provide more detail on specific situations.
And if I could just add something, Lauren, board members, if you look at, the first two columns under program-specific grants, that first budget line says $7,064,000. That's essentially exactly half of the revised budget. And I think it's just, is it correct, Lauren, that you basically take 6 months, since this is June? If the full budget is for $6,918,000 from El Paso County, it's divided out into 12 payments. And in the 6th month, we have 6 months worth under budget. And then, because sometimes things come in not exactly evenly like that, under actual, it may not be exactly 6 months worth. It might be a little more, a little less, but then it kind of evens out over the next few months. Is that right?
Yeah, I would say that that's a good explanation. And yeah, for grant-specific revenue, we did recognize more than 50% at June. So yeah, it should even out and maybe more, but I can provide more information with the projections of what we anticipate the rest of the year to look like.
And I think that's where Hunter's, and I'm sorry for interrupting, but I think that's where Hunter's suggestion will show that. We're still projecting exactly dead on in the rest of the year, but go ahead, Dr. Chan.
We have two different charts, and they're not quite the same. I'm not really sure.
That's the next month below it.
Okay, so the first one is for June, and the second one is for July.
Yeah,
Okay.
normally we would, present each month, but we didn't have.
Okay, I gotcha. Okay. I think the other thing that might be a little bit helpful, not to make a chart overly complicated, but perhaps a separate chart, is to show the year-end budget for the previous year, because to my recollection, we had some shortfalls in the licenses, fees, and permits, and perhaps also the grants, because of the timing, and also because of the changes in the fee structure. It took 6 months or so to catch up, which you did project. And so I think it would be helpful to see the year-end budget, maybe in a separate chart for the previous year, and compare how we are doing with the variance, because this looks great, but part of it is that we, at least to my recollection, are making up for a previous shortfall or lag. Is that correct?
I'd have to do some comparison to last year. I've really been focused on this year, but
Okay.
I feel like pulling that information in would
Okay.
be easy to do.
Okay.
I won't
Thank
let
you.
Lauren move on to July here, but do you have a comment, Commissioner Dana,
Well,
or
just
a
kind of a
question?
follow-up on Dr. Chan's comment, since I was not here last year, to see the dip or the deficit in that licensing fees that you thought would come. So how was that rectified last year? Was that taken from reserves, or was that shuffled around through other budget surplus items? How were those fees or how was the deficit covered, if that deficit was there at the end of the year?
And I don't know that Lauren really is, I mean, she might take some questions and then come back with answers next month on this. I don't want to put her too much in the hot seat. Deanne, did you have anything?
Somebody may remember in the
We
room.
did take $900,000 from reserves going
Yeah.
into this year.
It's tough to do it on your feet, just off the top of your head, though. I just think we should give her a chance to look it up, but Deanne.
I would be happy to come back with more specificity. However, yes, we did use fund reserve dollars for shortages in environmental health where licenses and fees had not yet caught up. And this is an area where we are making progress towards decreasing the need for that. both in our budget planning for this year, we took into account revised fees. We also did a deeper assessment on expected inventory and revenues to help set the process up better to begin with for this year. But yes, last year fees did not cover as much as we had anticipated. They came in lower than projected, and although we stayed in our spending authority, the revenues did not come in as high as had been projected, and we took that into consideration in developing this year's budget.
So where we're saying we're catching up, this is the expectation for next year. So when we say we're catching up, we're not expecting this to go down next year because of a lag. We're actually expecting it to continue on this trend.
We're expecting to continue to decrease the need for additional funds in EH through a better budgeting process, as well as increased fees, and then through the state legislature, increases were approved for retail food, which will also help increase our cost recovery for environmental health.
Okay, thank you.
Okay, Lauren, you got through June. Let's see how July goes.
I can walk through it. Again, it's the same information, but the only thing I guess I would highlight is here the operating expenditures trend looks like we have a negative variance, but if you compare that to our actual budget for the year, we are on track for our actual budget, and that variance is just related to timing of expenditures and compared to previous years, but we're not overspending in this area. The rest of it pretty much is the same, but I'm happy to walk through line by line, however you guys would prefer.
Are there questions for Lauren on July? No?
And
Okay.
I was just asked to add one update. This isn't part of my normal budget presentation, but we did get notification that we're going to be receiving additional federal dollars for our core immunization services contract for 2026 fiscal year. So that will be reflected in next year's budget, but we are going to be receiving an additional $180,000 and $480 of federal funds for that contract. So just wanted to let you know that.
And
Yes, please
if
go
I may
ahead, Deanne.
just follow up with that. If you'll recall, in some of our contract presentations for June on our state fiscal cycle, there was some discussion about delays on some of our state contracts, and that state was releasing some of those contracts with only the state dollar portion while waiting for the notice of award from the federal government. So as we move through this year, there may be other instances of a similar situation where we first receive the state dollars and then we have option letters that provide the federal dollars as those become available. And so we had just wanted to close that loop with the conversation from June and let you know that those additional federal dollars have come through for immunizations.
Great. Yes,
Is that
Commissioner Nelson.
something that we have to request those funds, and kind of, is it a grant that we're going after, or is that just automatically the federal government is providing to all public health in all counties?
And I'd be happy to address that. So our immunizations grant is with the state, so it is allocated to us through the state. But on the state side, when they contract with us or give us those grants, there is usually a mixture of both state dollars and federal dollars associated with that. The original budget we received only reflected the state dollars, and we don't have to seek approval or request those additional dollars. They're being added through, I believe, option letters as those funds become available to notify local public health agencies of the availability of those funds.
Okay,
So
thank you.
augmenting the approved contract.
All right, thank you.
And thanks for that clarification, Deanne. Anything else before we let Lauren off the hot seat there? Okay, great job, Lauren. Thank you for the presentation. And with that, we'll move on to item number 7, which is the director's report, and I get to hand this off to my partner here to my right, Deanne.
Thank you, and good morning. I would just like to first start by saying thank you to our new board members, Board Member Saltz, Mayor Dixon, and Commissioner Nelson for your time in coming and joining us here at Public Health for a new board member orientation. I enjoyed the opportunity to have some individual time with each of you, along with our board president and our acting deputy director. Look forward to working with you all as we continue to move forward. And today for the director's report, we wanted to first start with our tuberculosis program. And the reason we have tuberculosis on the agenda for you today is when we presented this contract in June, there were some questions from the board that we had indicated that we would come back to address at our next board meeting. So following up on that, we have Erin Huser, who serves as our tuberculosis program manager, here to provide additional information regarding our TB efforts.
And good morning, Aaron.
Yeah, good morning.
Go right
Good morning.
ahead.
So I'll be doing a quick presentation for you guys about the TB program, and then also following up on some questions that, in particular, a question that Dr. Vu had as well. So, do I have the? Okay, thank you. So before we started, I wanted to just go over quick TB basics. So TB is a bacterial disease, so there's not an effective vaccine that can prevent pulmonary tuberculosis right now. TB is a curable disease, so this is something that can be cured with antibiotics. And the disease is very serious if it's not treated. So mortality rate for this disease, if untreated, is as high as 50%. So there's two different kinds of TB we tend to worry about. So there's latent TB that we'll talk about, and then also TB disease. So latent TB, you can have the TB germ living in your lungs, but your immune system is essentially keeping it under control, kind of like having it walled off, like in the bottom left of the picture there you can see. So you won't get sick at this point if you have a latent infection. You won't be able to spread it to other people. But over time, latent TB infection can turn into TB disease, and that's when we get particularly worried about it. So TB disease, sorry, can you go back one? I'm not sure who has the clicker, thank you. So TB disease is what we refer to as active disease in a lot of cases. That's when a person can feel sick, you will have symptoms, and you can spread the disease to other people. So that's the real public health concern with TB. So, and of course, it's a very deadly disease. Okay, next slide. Okay, thanks. So how does TB spread? TB spreads through the air, so it's an airborne disease. This can hang out in the air for a period of time, so this can build up in the air, which contributes to its transmissibility. So transmission tends to occur over longer exposures, so it's not the same as like the flu or something like that, where you're looking at a period of minutes. Generally, exposures in the period of hours are more of a concern. And transmission depends on a lot of different things like airflow through the room, how sick the person is who has TB, and the susceptibility of the person who's being exposed at that time. Okay, next, yeah. Okay, so just to talk about TB treatment, so latent TB infection, as I said, both of these are treatable. So latent TB infection has a shorter treatment duration, but it's not a short treatment duration. It's 3 to 4 months typically to get treated for latent tuberculosis. So this is a preventative treatment. So we highly encourage it, but only about 10% of people with a latent TB infection, in between 5 and 10% actually, are going to have active TB disease at some point. So. But we do highly encourage this. It's not something you want to worry about as you age and have other health conditions. So anyone under the age of 18 in Colorado has directly observed therapy. That's our staff watching them take their medications, every single dose for the whole treatment. And we have some different ways to make that less cumbersome. You know, we can do that with an app on phones nowadays. Active TB disease is going to be a multi-drug treatment. You're looking at typically anyway, 4 medications. That can go from 6 to 9 months. Depending on the severity of the disease, it can go longer than that. So it's a very long treatment. Every dose for somebody who has active TB disease requires directly observed therapy, so we watch every single one of those doses. And then we can become non-infectious shortly after starting treatment, which is really nice. So we'll talk about what we used to do here in a little bit. Not as nice as antibiotics. Okay, next slide. Okay, so why do we have a TB program? So we're going to check out a little bit of, you can go to the next slide here. I don't know who I'm talking to, by the way, so thank you, by the way. I'm not sure who's doing that. So the history of TB, I wanted to include this Christmas seal. This is how they used to raise money for TB sanatoriums, and this is how TB was thought of around the 1940s. So it's this ghost that's coming into your house to attack your family. And so for other history, TB bacteria was first discovered in 1882 by Dr. Robert Koch. It was actually thought to be hereditary before that discovery. And prior to that discovery, it was also referred to often as consumption because they weren't really sure this was caused by an infectious disease. So, and consumption because over a period of time, people will lose a lot of weight. This is a really, really difficult disease to deal with. So. It was a leading cause of death in the U.S., so 1 in 7 deaths in the late 1800s was caused by TB. It's estimated in colonial times it could have been as high as 25%, so that's really, really high. First antibiotic treatment developed in 1943, that was streptomycin. Still had a lot of problems with treating people with that, with having the infection come back or the disease come back because it was a single drug therapy and they still weren't sure how long they had to treat this for at the time. So, and in 1953, CDC started gathering data on TB, the National Tuberculosis Surveillance System. We're still collecting that data today, and we'll actually look at that here before too long. So. Okay, so here's TB in Colorado. Here is, as I said, treatment used to look a little different than it does today. These are called gardener huts here these gentlemen are sitting in, and they would be the lucky people with TB that actually got to have what was considered treatment. So fresh air, sunshine, and these huts were designed to have lots of airflow through them. In Colorado, very interesting, about 30% of our residents around 1900 moved here for TB, so very interesting. We had about 45 sanatoria at the time, and nearly half of them were here in Colorado Springs. So really, really interesting TB history here. So, and the idea was that our air had a curative effect. I think that was probably marketing from the people who built the sanatoriums. So, and if you go to the next page, if you want to get totally nuts in Manitou, that's the name of the place. I wouldn't, not a recommendation, then you can actually see some of these huts that have been repurposed for other things these days. So they're actually all over down there. It's really, really cool. But we don't do that anymore. We're able to provide a lot more freedom for people within potentially just a couple of days. People can just go back to their normal life with our treatment, which is great. So. Okay, but it's important to remember, especially if the slides we'll check out after, that TB is not a disease of the past. So it continues to be the world's deadliest single infectious agent. So there are some things caused by infectious agents that do cause more deaths per year globally. However, as far as a single infectious agent, TB is the deadliest. So it was responsible for about 1.25 million deaths in 2023 and 10.8 million TB disease cases. So it's very much a problem globally. We have really low rates of TB here, and that's just because we've had excellent public health response over a very long period of time, and I'm very proud to continue that tradition. I never thought of TB growing up, and I want that to continue for other people. And so TB, sorry, not the television, TB investigation and control is mandated by the Colorado Revised Statutes. And I just thought that kid was kind of cute, and he's a TB patient. So this is what the NTSS, or the National Tuberculosis Surveillance System, data looks like. So this is 1953 all the way to 2023, which is the last year that we have data for. So we've got our TB cases here on the left, and you can see the long period of time that it's taken to get to where we are. This has been kind of a downward trend over a period of decades, so a really, really good sustained effort. And TB deaths used to be nearly 20,000 in 1953. That's actually pretty good compared to the history in our country. But nowadays we're closer to 500. So, and that's just been, I just wanted to show those trends over time. And that's just the result of basically one of the biggest public health wins, I think, in the U.S. So what do we look like compared to other people in El Paso County? This is a great slide for that. So in 2023, the incidence of TB, so it's important to remember incidence is the amount of new cases in a period of time. Prevalence is the amount of cases that exist at a period in time. So this is the amount of new cases. So globally, we're at 134 per 100,000. That's really, really high. And way down here is the US at 2.9. So that just shows, we're getting out what we're putting in on this. We do a lot of work and we get a great result for it. Colorado is actually lower at 1.5 per 100,000, and El Paso County sits at 0.7. So we're below the national and the state average here. Okay, so let's talk a little bit about the TB program. Might see some familiar faces on the next slide here. Thank you. This is the TB team and our TB contributors here at Public Health. So we have 3 full-time employees. We serve 750,000 people. That's 2 registered nurses and 1 disease intervention specialist. And the disease intervention specialist is like a non-licensed support staff, but they do a lot for us. I couldn't run the program without them. So great. And then we have surge support from the agency. So we have a large outbreak. CD can get involved in emergency preparedness and people like that. So the Prevention and Control Grant, that's the one that we just recently renewed here. So the grant responsibilities, treatment of active TB disease. Of course, we treat every case of active TB disease in the county. Latent TB treatment, of course, is a big part of what we do. Risk assessment, evaluation, and testing. We can do that based on cases that come down from the state or also consulting with other medical providers. And contributing to the TB data system, and that's actually informs the national data. So what we do here goes to the state level and then goes to the national data. And a case and contact investigation is really important. If we just treat a TB case, what about all the other infections caused by that? And that could turn into active TB. So by doing those case investigations, we're preventing TB potentially decades in the future, which is cool. Mm-hmm. Okay, so we also provide a lot of support to local medical providers. So we do consultations on their cases, just guidance on what tests to do next, for instance. And we also accept TB case referrals. So if they get to a point where it's not practical to manage safely at the provider level, then we will actually take over that case, bring them in here, rule out active TB, and then we can either continue to have that case or send them back. We do advanced testing and case management, sputum testing. It's safest to have that done here. If there's a concern for TB, we have isolation rooms that we use for that. Isolation guidance, how do I make sure I don't get my family sick? And then evaluation and risk assessment, of course, that's just what we do when people come into the clinic. And then complex treatment scenarios like minors with latent TB infections, we'll take those cases over. So this is not a staged photo, no matter what you might think here. We have not done a good job of photographing these events, but this is what it would look like if I were doing a UCCS student presentation. We have multiple cohorts of those guys come through, and we teach them a little bit about TB, which is not a big topic in nursing school. So this is probably a lot of their TB education, so I love doing that. We did also staff education at Springs Rescue Mission to kind of let them know you're working with a high risk population, and these are the things you might want to watch out for. And call us if you're seeing any of these concerning things. And then also, actually, here in about an hour or so, I'll be doing an enhanced case management meeting where I'll detail one of our complex TB cases for all the TB staff in the state. Lots of PowerPoints. So to Dr. Vu's question in the last, he was asking about demographics. So I wanted to, again, start at the national level and move down to the local level here. So this is what Colorado kind of looks like on the left-hand side here, TB-wise, compared to the rest of the country. The lighter colors are less TB, darker colors are more TB. So we have under 100 cases pretty consistently. So you can see most of the Midwest is about like that. This pie chart on the right-hand side is TB rates by origin of birth. So 76% of cases in 2023 were non-U.S. born persons, and then U.S. born accounted for 24% that year. Okay, so top 5 birth countries of people with TB disease. So this is people that were sick with TB over the last 8 years. And this is Colorado versus El Paso County. So you can see for us, about a third of our cases were U.S. born, followed next by people from the Philippines, which does differ from the state average. And here's just a more demographic information, us versus the state. In some ways, like male to female, we look pretty similar. That's globally, that's about what that looks like too. It's more likely in males for whatever reason. 18 to 64 accounts for the majority of our cases. And 49%, or about half of our cases, are Asian non-Hispanic, followed by white non-Hispanic. And so we had 41 total cases over this 8-year period, and that's about 5 cases per year. And this just details risk factors. Like this was in particular, I think what Dr. Vu was driving at, the risk factors of people with TB. And so as you can see, when we list the top risk factors, a lot of people don't necessarily fall into those categories. So there's not like necessarily like a single risk factor that jumps out. But this also does prove that there are some things that can make it more likely for you to have this issue. And just to kind of recap, historically, this was a leading cause of death in the U.S., not even close anymore, which is wonderful. A strong public health approach minimizes the threat to our residents, because TB does continue to be a threat to people. Tuberculosis intervention is statutorily required, and then we serve the community essentially through specialized expertise and support of our medical community. Any questions about? That was a lot, so.
Hunter, go ahead, and then
Thank you.
come back to Dr.
Thank you for
Chen.
that.
Sorry,
I-
Dr. Chen, I can't
I
see you
learned.
because you're right next to me.
I learned a couple things today, so
Cool,
thank you.
all right, excellent.
A couple basic questions.
Yeah, sure.
So there's no effective vaccine.
Mhm.
So how does one not get tuberculosis?
Yeah, essentially, you don't get exposed. So it works really well here in the U.S., but just to clarify, there is a vaccine that is given that you might hear about called BCG in other countries. It only really prevents severe forms of TB in like little kids, so you don't want them to get like TB meningitis or something like that. But truly, yeah, just not getting exposed is the best way, yeah.
And then my second question you started answering is, so is there an environmental vector, or is it truly someone has to cough on you and you shake their hands and you don't wash your hands and you touch your face? I mean,
I love that you brought that up, because we had a guy who offered to talk about bovine tuberculosis recently. That's not what we're worried about. So it truly is person to person. And even if you have a TB, like an extrapulmonary, what we would call, so you can have like TB, brain, kidneys, spine, things like that, that would not be something you'd be worried about spreading to other people. It's truly when it's in your lungs and it's growing in there, someone's coughing it into the air, that's when you have to worry about it.
Okay, last question.
Mm-hmm.
So 5 cases El Paso County per year on average.
Yeah.
Where did the exposure come from? Do we know? It's just really odd connecting all the dots of the facts that you said. I'm trying to understand, especially within the context of the social factors slide. I'm very surprised that 80%, can we go back to that slide?
Yeah,
it was
I
like
think it's
81%.
maybe 2 back or something.
None on social risk factors, 63%, none on comorbidities. That's just like the opposite of what you typically would find, I think, for someone at a high risk
and so
for a disease.
Read none as could be other less common factors on that too, because these are sort of the top factors that the state was able to provide me. So I kind of, it's not that there could not be another social risk factor that could, like for instance, if you were like in a refugee camp at some point or something, that could be another social risk factor. But we listed the ones that are most common here in our community. So.
Okay. Okay. Thank you.
Good questions, Hunter. Dr. Chan?
Thank you for the presentation. It's really, really good.
Thank you. Cool.
There are 2 diseases in the world that scare the daylights out of me, and that's measles and multi-drug resistant TB.
Yeah.
I've worked in areas where TB is endemic. I've seen children paralyzed from Pott's disease.
Yeah.
I've see, I've had to take oxygen off of one person because they weren't going to make it and put it on somebody else. So there's nothing that scares me more.
Yeah.
And I applaud you on this excellent presentation and the excellent control that we have in El Paso County. When I was in medical school in Alabama, the sheriff could arrest somebody and put them in jail to make sure that they receive their treatment. That's how dangerous this disease is. So I'm glad that you have, your head in the game. The question that I have that really stood out is the percentage of cases in El Paso County, 49% Asian, non-Hispanic. There's hardly any Asians in El Paso County. I mean, what is the population of Asians, like 2%?
It's a big part of the world. So, I think our second group was from the Philippines. It looks like on there. So, it's out of 41 cases too. So that's why I pushed it past the 5-year mark and went to the 8-year mark, because I just wanted to get as far out as we could to try to get the most relevant data. Yeah.
So for regular migration, in my experience, regular migration into the United States requires screening for TB.
Yeah.
So what happened? How did the 2% of Asians in El Paso County suddenly account for 49% of cases? Was it regular or irregular migration?
We tend to, I don't know if I can answer that right now necessarily without looking at those cases. I don't track the status of. But I will say one thing. Could we go back to the 2 pie charts? Is there? So they won't necessarily account for. I think the train derailed here. I apologize. There's some limitations to the way some of this data looks, so I might have to address that another time, because that's not something we necessarily track. I don't think, because people can come here from other jurisdictions as well, so, sometimes we get people that come here and they have TB disease from like another jurisdiction, and we're just like sort of trading it off. So I don't know if I can answer that question right now.
Could it be something like a family or a church, and then that sort of just,
actually
we didn't catch it fast enough, and so that could have really been the numbers or something?
And I think that's what I was trying to get to before I totally forgot what I was going to say, which is, so the data can be really skewed. So if it is like someone in a home and there's like 8, 12 people, whatever it is in the home, if multiple of those people were to get TB disease, then it'll heavily skew the data a certain way. So, thanks for that.
It looks like Dr. Albanese is behind you. She'd like to.
Come on up.
Thanks. So, we live in a global society now. That's no surprise. You can think about it in many ways, whether it's economically, whether it's travel, whether, It's just we live in a global society, so people move around, and that's our residents going to other places, other residents coming to our places, whether it's to live or visit. So, there are sections internationally. There are sections of the world, as you mentioned, Dr. Chan, that have very, very high, and it's really prevalence of TB disease without the type of public health control that we have here. So we find out about someone with active TB disease, and we are all on it. And our goal is, first and foremost, from a treatment perspective, you're trying to treat the person and save their life. And then from a public health perspective, in addition, we want it to be contained. And so we use effective medication, which in the beginning renders that person not contagious, and then we continue the treatment so it stays that way and their infection gets cured, so the risk that they're going to spread stays gone. That is not necessarily the situation in lots of other countries. And so, anybody with enough exposure to TB may get infected, and so it's just there's a high amount of disease in the Asian continent, a tremendously high amount of TB disease. And so, folks coming from those regions that relocate to the United States or relocate to our county, at some point may develop their TB disease. They may not, as soon as someone comes over and decides and chooses to live in the United States, doesn't mean that their TB disease may wake up. They all started with latent TB infection. It doesn't mean their TB disease is going to wake up as soon as they get here. This could happen 10 years later, 15 years later, 20 years later, when your diabetes developed or you develop cancer and you go on your therapy, or if arthritis, you go on your therapy, and then boom, it happens. And so the demographics in the United States in some ways reflect where we have movement from the United States or between the United States and other countries with a lot of TB disease. And so it doesn't matter to us. This information is just presented to us, the individuals that get diagnosed, and we treat their TB disease, and then we record information about them, and the surveillance continues. But it's not, you are correct that with proper immigration, someone is screened. Many of the individuals that we get referred to the health department for latent TB treatment or have been screened, and we rule out that they're not contagious form of TB. We rule in that they have TB infection, and we really try to get them treated so we don't end up with a problem 10 years later. So TB control is so much about, it's not just, well, you're contagious right now, let's get that taken care of. It's about, let's think 5 or 10, 15 years down the road and contain what we can now and get people successfully treated now so they don't activate later. I hope that helps.
Yeah, well said.
I
Thanks
think
for
it
that.
does.
Yeah.
Dr. Shan, do you have a follow-up? And then Commissioner Geithner has a question, and Dr. Vu has his hand up online.
Yeah, so is there an avenue by which people, maybe they don't have to declare their immigration status at the time they are seeking care for other things like reproductive health? Is there an avenue where everybody is offered screening? Because a good portion of the population may not have come through with regular migration, and they're not screened.
Yeah.
So is there any kind of program or avenue by which they are offered that screening irrespective of without having to declare their immigration status?
Yeah, we don't collect that information, and so we try to make sure that we're heavily geared towards, we don't want you to be sick because it can get other people sick, and we want, and so it truly we're geared towards just protecting the county. So we don't ask people to necessarily declare their immigration status, but I know what you mean, that it is tricky because if somebody comes in and, for instance, the government doesn't know about them, how would we know about it? Well,
Right.
we wouldn't. But we do we do perform risk assessments and treatment on essentially anyone who's not able to get that treatment and assessment elsewhere. So if someone has like no insurance and no primary care doctor that they can see for these tests, then we would do that. So I guess that's kind of what we can do there. And so yeah, I think that helps people. It reduces the barrier. Basically, it's a low barrier clinic here. So.
Okay, and one last follow-up with my last question. How do you determine whether somebody has TB that is amenable to standard treatment or multi-drug resistant?
Yeah, we actually do some genetic testing that helps with that, and then sometimes we'll order special sensitivity testing if we have to use for age-related things or because of a medical condition, use a different treatment using like Levaquin, for instance. That we might want to know, is this specifically susceptible to that? So we can order susceptibility testing through the state.
Thank you.
Yeah.
So I just want a clarification because of the difference between the latent and the active and the screening through regular immigration is the way that you described it. And I'm so sorry. What was your name? I apologize.
Bernadette.
Albanese? Yes. Okay. Every time you say it, I'm like, I can't quite get all the words. Albanese. Got it now. You mentioned, though, that, sometimes it may be latent and pop up 10 years later. So the screening does not include screening for latent TB then?
Yeah.
It's only active. Oh, no. So in theory, then, someone should, if they have come through regular immigration channels, legal immigration channels, should not have latent either. So it should not pop up later, in theory at least.
So you can be, they will do TB testing overseas, and if those physicians essentially rule out an active disease at that time, they're allowed to come in through this immigration process, and that's where, like, there's Class B status. So if there's no TB, this gets really complicated. There's a couple different Class B statuses, so things that could indicate a latent infection, and they would come to us. We will, again, rule out active disease, even if it's been done already overseas a few months ago. We'll do that again, repeat chest x-rays, and make sure there's no active disease. But the treatment for latent TB is not required. So we strongly encourage people to do that. We always tell them, don't make yourself worry about this for years. Let's just get it out of the way and be healthy.
Okay, so what I was trying to assess is whether it is likely that some of these cases are those latent cases happening later, and it sounds like the screening could happen, they could be identified, but they could choose not to be treated at that time, and then we would see that later on.
Yeah, could be, yeah.
So that could be one of the ways through the regular process. Okay, thank you.
Yeah.
Okay, Dr. Vu.
I just want to thank you for the presentation. That's all. Thank you.
That's a great
Easy
comment,
question.
Dr. Vu.
All
And then, Aaron, I
I
just,
have one more comment. So the other important thing that Aaron does, and I work with the TB program in my position here, is contact investigation. So when we find out about someone who has contagious TB and we start getting their treatment and we repeat our testing to make sure that their cultures are negative, their sputum says can't find TB anymore. It still takes 6 to 9 months to treat it because it's a persistent little bug. But we then do a contact investigation. So we investigate who that individual has been around for a prolonged period of time, and sometimes we have to go weeks and months back. We then reach out to those individuals and say, hey, can we test you for TB? And we do find it. We do find that spread. And then at that point, we are right in a great position to offer their treatment for their latent TB infection at that point in time. And they're scared at that. Like, most individuals will be like, whoa, what just happened? And so we get good uptake in those situations about people actually accepting treatment because they understand what their risk is, and they're often, our treatment completion success is actually quite good with contact investigations. So that's another big part of what the program does, and an important way to keep it from hopping out in the community.
all right, thank you. And Aaron, my only question is, do you get referrals from military installations from Carson or
Military
others?
likes to do their own stuff a lot of times, so we actually will notify the military sometimes if we have a person, but we would take it, yeah. It's just they prefer to do their own. They use INH a lot too for LTBI.
Yeah.
That's interesting.
Do they used to send folks to you, or no?
They haven't since I've been with the program for the last couple of years. So.
All right, thank you.
Yeah.
Okay, Commissioner Nelson.
I am curious to learn more about the medication and the options. It sounds like there are multiple possibilities when Dr. Chan said multivariant or multi-drug resistant, but I just wanted to know, is it a common medication that we have sort of availability security, or is it something that is very unique and specialized?
Yeah, so rifampin is mostly used for TB. There's a couple other things they use it for, but so rifampin's kind of like our most loved TB drug, followed by isoniazid, and then we use a couple other medications, but there are other treatments that you can use that are different. They're all in that kind of rifamycin family that we have a couple different drugs we can use in there. So, yeah, I don't know a lot about the supply, to be honest. We've never run into issues with that. We've been able to get, there are some really specialty medications, like if you get a drug-resistant form, that are a little tougher to get. And we actually have contacts, other physicians that have been through that process that have agreed to actually help us if we should ever need to get those. So we've kind of thought about that too, because that's one of our fears as well.
Yeah. Did you have another comment?
Add a little bit more to that too.
Go for it.
So when you have a lot of disease like TB in the world, you also learn a lot about it, right? There's a tremendous, and there's been decades and decades and decades and decades of research on TB treatment to get us where we are today. And so our tried and true regimen for TB disease is a 4-drug regimen, and we will start with that regimen typically out of the gate, unless for some reason right out of the gate we're worried about drug-resistant disease. And so, for example, if someone is a contact of someone that we already know have drug-resistant disease, we might change it. Majority of the time, we can start with that 4, and then, that goes for 6 or 9 months, and we make adjustments as needed based on follow-up testing. Those 4 drugs are typically readily available. They're not special drugs that you hear about used for other conditions very much. It's not amoxicillin, it's not Bactrim, it's not Levaquin, right? They're different drugs. And then we have a portfolio of other antibiotics that we can use if we're getting test results back that are concerning. Or, we can have side effects too, and sometimes we have to tweak regimens because a patient's not tolerating a particular drug. And so one of the other very fortunate things that we have in Colorado is a very strong internationally recognized TB program out of Denver Health, and so they help us when we have to sort things out about a challenging client or lab results that are concerning. And so we have local backup advice with the state health department that we can get. And so we feel very confident when we're managing our patients, and Adam's team is taking care of our patients, and we have sort of layers of consultation as we need it. So the program is strong and very sound, and we that's why providers, they refer TB cases to us. Active TB case becomes our patient. It starts with another provider, and then they become ours because they know that handoff is imperative for us to get to the finish line and to make sure the patient does well. And so Aaron's phone is always ringing in terms of, I'm not sure, help me, what test should I get, whatever, and we help facilitate that. We review x-rays and things like that, and then we help out. And then once TB is established, they become ours.
And that was going to be my next question. Can you speak a little bit to the testing process? Like in this presentation, you had pictures of images of the lungs, but what would testing look like?
So a lot of times, so if, let's say someone's coming from overseas, they would get a lot of times a QFT overseas, and so that's just a TB test. Have I been exposed to TB or not? They'll do an X-ray if the answer to that is yes, and if that's got anything abnormal on it, they'll go ahead and do sputum. If that's negative, they can pretty confidently say, okay, this looks like LTBI, but if we're going to go over there, we want Aaron and his team to investigate this person. So we'll reshoot the chest X-ray. We don't redo the QFT because there's no point. It's going to be positive forever if it's positive. And then we'll redo that sputum testing at our state lab here. And that's usually how it, kind of a really, linear way of how we assess those. But diagnosis of actual TB disease is not always very straightforward. There can be situations where I've had multiple sort of obvious, I guess, what you call obvious TB cases that had negative TB tests. Just their body's just overwhelmed. They can't have that immune response. So you have to look at the imaging. You have to look at the symptoms the person is having, and risk factors that they have, and take that all into account. And that's how you build the picture of TB. So you can't really rely on one test. That's why we do all these different things and look at all of that together.
So you mentioned partnering with organizations like the Colorado Springs Rescue Mission, because that may be a population that is at higher risk.
Yeah.
What are some of those symptoms that you're coaching them on looking for?
Yeah, so a lot of times with TB, the kind we're worried about spreading in a place like that would be like pulmonary TB. So a cough that's lasting longer than 3 weeks, if you're coughing and you're having blood come up with that, and it's usually going to be a productive cough that's persistent, really heavy night sweating. This would be like somebody poured a pitcher of water on your bed when you wake up, and also weight loss over time that is not well explained otherwise. Those are really the sort of, if we hear those things, I'm like, bring them in, tell them to put a mask on. So those are the main TB symptoms we're telling them to watch out for.
Okay, I know I'm asking a lot of questions, but this is really interesting, and I like to learn, so bear with me. When you say you have 5 cases per year, is that latent and disease?
No, that's just the TB disease cases.
Okay.
So latent cases, we will treat quite a few more of those than,
Yeah.
than we do the active.
Do you have any sense of what those numbers look like? Because
Um,
they keep your team busy, because that
I
was
do
going to be
this
my
year.
next question.
This number's going to go up rapidly
Yeah.
in the next month here, but so far through June, we had 12 new LTBI cases started, and it looks like this year we've been averaging between 10 and 12 that are being treated at a time. So if we have a couple new ones, then a couple are completing treatment. But I think we're getting ready to start probably 6 or 7 people the next month or so, I think so.
So you said 10 or 12 a month, or what was
Oh,
it?
no, just so far for the beginning half of the year through
Oh.
June, we have started 12 people on LTBI treatment.
Okay. Can you say that acronym, LTV?
Oh, sorry, LTBI, yeah, latent TB infection. So,
Okay, thank
yeah.
you. Okay, yeah, that was going to be my next question. Just 5 cases per year doesn't sound like a whole lot
Yeah.
for a team of 3 or
Sure,
4-ish
yeah.
people, but, so I just was curious, do
Yeah.
your staff also serve in other areas within the organization?
We don't, and I know it doesn't sound like a lot. We've actually done 681 directly observed therapy visits just in the first 6 months of the year, and 231 of those were actually at people's homes. So we have just different scenarios. People have to go to work. They can't take off work to come here. So we'll even go out in the parking lot of somebody's job and watch them take their medications and whatever it takes. So we do there's a lot of care coordination that we didn't discuss here that goes into this. Like if someone's homeless, they have to be isolated somewhere. So we have to find a place for them to be isolated safely, where they have food. Actually, with the nutrition background, one of the biggest predictors of TB disease, if you have a latent infection, is poor nutrition. So yeah, there's a lot of case coordination that goes into it. Like if there's, we may have to provide somebody with a cell phone, we set them up on their video app, just getting records and making sure they get to the end of treatment, and then we present that case to the state, and then the state can say, yes, this person has been treated adequately. That's one of the services they provide, is sort of a double check on, yes, this highly unlikely this person relapses into disease. We can end this case now, and so there's a lot of other stuff that goes into it.
No, I really appreciate you expanding on
Yeah.
what your department and how they're serving, because that helps me to understand as
Yeah.
a whole what our organization is doing, and that is going to play into your budget. I mean,
Yeah.
providing someone, if they're homeless, somewhere to stay, and a cell phone service. I mean, those are costs that are very real, and
Yeah.
something I would never have realized that you're having to help provide
Yeah.
for. So thank you for
Yeah,
expanding.
absolutely.
And great presentation, and
I
thanks
could
for
talk about
humoring
this
me.
all day, so.
Yeah, me too, apparently.
But you
One
guys
last
might
quick
move on at
Unfortunately,
some
we don't
point.
have all day, but
One
go ahead.
last question. So are you and your team regularly testing yourselves, given the exposure?
They never do
What
that.
a timely question. So I just got tested recently, so we're initiating annual testing on the team now. So it's we do need to get tested on the way into the public health department, and then we're instituting annual testing now. That's the lead public health nurse is working on that with the clinical services division director. Yeah.
I'll just point out, in the military, every time you deploy overseas, like if we go to Iraq, you get tested before. Well, you always get tested when you come back. I think we got tested beforehand. It's when you come back.
Yeah.
So, yeah. Yeah, if you go overseas, then this is part of the process. And, there's a good number that'll come up positive on the test when they come back to the States. So,
All healthcare workers are also tested. If you
Annually.
refuse testing, you, as a physician, for example, you lose your hospital privileges. So once a year, all healthcare workers are also tested.
okay. I think I hear a pause, so we're gonna move. We're gonna take
Thank you.
it. And thank you, Aaron. Great presentation. Very well done. And with that, I'll hand it back over to Deanne.
Thank you. And the next item that we have for you this morning is a brief overview of our strategic plan, as we're welcoming new board members into this organization. Wanted to spend just a little bit of time sharing our strategic plan with you this morning. and we have Michelle Byerly, who is our acting deputy director, as well as overseeing our strategic data and communications teams.
Wonderful. Thank you so much,
Yeah,
Director
good morning,
Ryberg.
Michelle.
Good morning, board members. Happy to provide a brief overview of our strategic plan this morning. And if we could go to the next slide, please. So first and foremost, the plan is grounded in our mission, vision, and values with a focus on promoting and protecting health and helping to create thriving communities. And our values are deeply rooted not only in what we do in our work, but the how and the why and the way that we approach it. And one of the first things that we did when we looked at beginning our strategic planning process was a careful assessment of all of these elements to ensure that they were still well aligned with our work and our priorities. And starting there, next slide, please. So the overarching framework for our plan is really intended to provide us with a core set of guiding principles and key areas of focus to help ensure that we're supporting strong decision-making and also responsible allocation of our resources. It is also set up in a way that is intended to be flexible enough to allow us to be able to shift and adapt to changing priorities. And when we set out on this process, one of the things that we did is engage an external consultant who also provided support to El Paso County in the development of their strategic plan. And really the intent behind that was to identify opportunities for alignment and a shared approach. And then each year, as a follow-up to this framework in our plan, we do create annual work plans that have specific performance measures that outline progress that we are making towards each of the priorities within this framework. We do report out on these in our annual budget books. So each year in our budget book, you'll see an update on progress that we made towards the previous year's performance measures, as well as future looking what we have planned for some of those specific measures for the year ahead. Next slide, please. So the plan is really comprised of 4 overarching strategic pillars that represent broad goal areas, and within these we have workforce, health data and communication, community trust and engagement, and partnerships. Next slide. So each of our strategic pillars has a broad goal along with several accompanying strategies, which you'll see on each of the subsequent slides. So as it relates to workforce, having a highly trained and capable workforce is essential to being able to fulfill our statutory responsibilities, providing our foundational services, and also innovating to be able to address emergent needs. One of the recent areas of success that we have implemented this year to support progress in the area of workforce development is a targeted leadership training series that we have brought to our management team that has been done in tandem with our El Paso County HR organizational development team. And it's included a variety of topics on everything from navigating difficult conversations to performance management to adaptability and change management. And the intent behind this is really to equip our managers throughout the agency with the tools, the resources, the skills that they need to be as successful as possible in their roles. Next slide. So when we look at health data and communication, expanding the ways in which we share data and information with our community has really been a focal point of the agency. And the goal with this is to help us get actionable insights to drive more informed decision making. A few recent highlights for this, which some of our board members may recall, we did develop 2 data dashboards, which we shared with the board last year, with information on overdose fatalities as well as suicide. And these visualizations do connect back to 2 of the priority areas that were identified in our community health assessment. We also last year completed an overhaul of our public-facing website with a lens on modernization and creating a more streamlined user interface, trying to make it easier to navigate for our residents while also working to gain compliance with some of our newer digital accessibility requirements. And then more recently, our communications team has been working on different strategies to increase our messaging around nutrition and physical activity. So as an example of this, we do have an upcoming article that will be featured in a local paper that highlights some nutrition tips and advice from our Women, Infants, and Children Division Manager for parents and families as they're sending kids back to school on some ways to help pack healthy lunches and help kids be successful as they're starting the new school year. Next slide, please. So community trust and engagement are incredibly foundational and instrumental to our work, and we remain committed to expanding the ways in which we are exploring the needs of our community and engaging input from residents to be able to help strengthen these relationships. So a unique example of something that we worked on over the course of the past year was an impaired driving data walk that we held in collaboration with the Department of Motor Vehicles, and that was last year as part of efforts to raise awareness around National Injury Prevention Day. So really what that event provided us with the opportunity was to learn more and engage with residents on the types of data that resonated with them. And so there were conversations around 4 different data perspectives and talking with residents about what impacted them the most. And really with this approach, looking at making sure that community concerns are at the forefront of our problem-solving efforts. So as part of the data walk, we had nearly 80 community members who participated, and they were able to share their feedback on sticky notes and put those directly on some of our data posters and have conversations with our staff. And a lot of what they talked about was, from a community standpoint, what surprised them the most, what they learned from the data, and also what solutions that they felt would be most effective for implementing in our community. Several community members also shared personal impact stories and were very interested in how to support the work moving forward. And the data that we collected from this was then used to inform the implementation plan and logic model for the grant in the previous year, so helping to support evaluation activities for our impaired driving grant. And then partnerships.
Quick question on that.
Sure.
Yeah, I loved hearing about that process, and there's kind of, we do similar processes at the county for different things, but one of the things that I think is always challenging is finding a representative sample of folks to come in. So how do you guys recruit for something like that?
Yep, so this was actually the first year that we did this, and it was held right outside of the DMV to try to catch people as they're kind of coming in for some of those county services. So I think it's probably a little bit of more of a convenience sample, to be honest. So that was kind of a pilot that we had done, and so we were really just looking to see if it was something that people would engage with and what type of feedback. So I think it's a great question, and we'll continue to explore.
It's always difficult to get people to volunteer to do it, so I can see how having a willing sample right outside your door is super valuable. I would just say I would love to see that, more of that continue.
Yeah, thank you.
But the people that you won't see coming into this building very often are the people who live in my neck of the woods, because we don't trek down here very often.
Yes.
And so just keeping in mind that whenever we're looking for ways to communicate to our community, we have a lot of diversity in terms of where people are and how they. So it's always good to try to reach out to those communities that can be very difficult to want to engage with the government.
Absolutely.
But sometimes those are the most important voices because that's who we're trying to reach, and we don't ever learn how to reach them. So thank you.
Well put, and we really appreciate that feedback. Thank you. And then partnerships. So one thing that we know for sure is that we cannot accomplish our work in a vacuum. Partnerships are instrumental in the way that we advance the efforts of our agency. So collaborating with a wide variety of multi-sector partners is really a cornerstone of how we're able to more effectively achieve our work. An example of this is highlighting the work of our emergency preparedness and response team. They work very closely with our Pikes Peak Regional Office of Emergency Management and partners really throughout the region to be able to plan, train, and prepare for a wide variety of types of disasters. So a sample of some of the activities and planning that they've completed this year in support of this partnership element is participation in a multi-agency coordination group with our local Office of Emergency Management. They were also part of, there's a South Central Region ancillary care tabletop exercise that looked at how we communicate and coordinate during an emergency between that coalition and our ancillary care facilities. They also participated in a full-scale ChemPack exercise, which was simulated ChemPack deployment in response to a mock terrorist attack involving a nerve agent. And then finally attending the Colorado Springs Utilities Dam Seminar, where the team was able to learn a lot of insights about dam safety, risk assessment, and emergency action planning. So even within just that one program, really a wide snapshot of how we work with partners to support our community and region. And then next slide. So
Michelle, go ahead. I think we're almost at questions.
Yeah.
Can you hold up? Okay, go ahead, Michelle.
I can wrap up briefly. I was just going to say that our current strategic plan will go through 2027, and next year we are slated to begin the planning process for our next 5-year strategic plan. And before I open it to questions, I would just say that this was really intended to provide a very brief high-level snapshot, but would be happy to do a deeper dive into any of the topics we've covered. And with that, any questions?
And I believe Mayor Dixon has a question.
Thank you for the presentation. I'm curious if there's a mapping of the emergency operations interactions. You know, because you mentioned PPR, OEM, you mentioned a couple other things. I'm just curious if there's kind of a mapping so that, you know, if something happens to, say, an individual within the health department, that we have this mapping, then they know where to go, or they know who to contact, and they know who's the lead.
That is a great question, and I might ask my colleague Janelle McNair, who actually oversees our emergency and preparedness response program, to see if she has any insight.
Hello, good morning. So can you elaborate on your question a little bit regarding mapping?
You know, say, for example, something happens to your existing staff. Do you have something in writing where someone can come in and say, okay, I know I need to coordinate with this entity, and say, you know, another entity may have a lead on something?
Okay, I think I know what you're saying. So
I call it a mapping.
Okay, so we work under emergency support functions. And so the Office of Emergency Management is organized in various emergency support functions, and public health falls under emergency support function 8, which is health and medical. So if there's something going on in the community where we would need to support an emergency or an event, we get activated by the Office of Emergency Management, and we serve as the emergency support function 8 lead. Then we bring in all of our health and medical partners to help support whatever emergency is occurring within the local jurisdiction.
And you have, you know, good descriptions in case someone else needs to step in on who to interact with. And because I'm sure PPR OEM probably comes in and says, okay, we got a situation, we've notified you. Now within the department, who does what?
Yes, so within the department, Emergency Preparedness and Response Team will serve as the Emergency Support Function 8 lead over at the Emergency Coordination Center. We do have myself as a division manager, and then 2 emergency management specialists that can serve in those roles. So we are 3, do have 3 deep, and that's because usually emergencies are 24 hours, so we have to have that 12-hour shifts. And so we are able to fulfill that role, and then in that role, we coordinate with subject matter experts back here at the health department. So if there was like a power outage, we'd be coordinating with our environmental health division in order to help support that emergency event.
Thank you.
Yeah.
Okay, and thanks for that, Mayor Dixon. Any other questions for Michelle today? And as she mentioned, we can go into deeper presentations on any certain pillar or certain topic underneath this in the future. Okay.
Thank you.
Well, Michelle, you've been very thorough because we don't have any questions, or thorough enough. We'll say thorough enough. All right. I'll hand it back over to Deanne for anything else.
Thank you. And the next item that I wanted to discuss with the board is our 2026 budget development process. To the question earlier about our fiscal year, we are currently in the process of developing our budget that will align with calendar year 2026, and wanted to just briefly orient the board to some upcoming dates and kind of working backwards. At our December meeting, that is when we present our original adopted budget to the board for your approval. But before we get to that December meeting, in October's meeting, we will have a preliminary balanced budget presentation to the board. And prior to that October meeting, I would like to ask if the board would like to hold a work session. We have different ways we could look at that, but hopefully no later than early to mid-October, to have time to work together with the board to answer more in-depth questions that you may have about the budget and provide additional insight and opportunities for conversations leading up to the preliminary balanced budget presentation. And if the board is amenable to that, I would suggest that we would send out a poll, as we have for other meetings, to assess availability with options from our September meeting to add on a work session to that meeting, or alternate dates if needed in early to mid-October. So looking for some head nods, and it looks like there's...
Yeah. So first, the board would like to do that work session. Is that correct? Okay. And then, I mean, the only way to like immediately resolve this is there support just for adding it to the September board meeting so we don't have to find another day, or would you like to do the whole poll?
I think that that is going to depend on the length of the board meeting, and I say that because I know that Lauren and I both have opioid counsel later in the day, and so it really, if we have a long meeting and then tack it on, that could run into that.
What time do you need to be finished? What time do you guys need to be done?
2, so as long as it's not super long. But there have been plenty of times where we have gone to almost noon here, so.
We're still here too. We got issues. What do you think?
So for the September meeting, we will have our programs that are renewed on a federal fiscal cycle, for which there are 4 items of conversation for that meeting. So we do have a fair amount of content to review at that meeting with the board. Alternatively, we could plan a shorter session and potentially a follow-up if we don't have enough time at that September meeting.
So you're suggesting, hey, let's add it to the September meeting, knowing that we're going to have to end at a certain time, and everybody can just factor that in with our questions as we see these contracts and things. Yeah.
Yeah, I think as long as we have kind of a hard time, and I think,
I'm
if
with
we
you.
have all of the information previously, we can all try and do our best to review beforehand. But I just think as a general statement, Dave, and I get it, we have a slotted time. As you well know from your service, most boards don't have that as a volunteer board, so I know we try to very much respect everyone's time. The reality is, though, I think it's very important that we don't cut off questions.
Sure.
We have a very important role to play as the governing board of the agency, so I'm willing to say, yes, let's give a hard time for that, and if we need to come back and do more, so that I don't want anyone to feel rushed through the contracts either.
Okay. Do you have
Yes.
an understanding? Okay, good.
Thank you. And then to that point of content for September, you have at each of your seats our packet of preliminary information. Amanda will also send out an electronic version of this. This slate are all renewals of previously approved contracts. So there is not an action item associated with them. However, we do want to present them in the cadence of the renewals so that we are moving forward together with understanding about the programs, the funding, and how we are proceeding. So in this grouping, we will have our Women, Infants, and Children supplemental nutrition program, the breastfeeding peer counselor component of Women, Infants, and Children, our drug-free communities, and our maternal child health efforts, all of which we receive on a federal cycle. And these packets will all give you information regarding these efforts, and then we plan, as we did in June, to have presentations from our subject matter experts related to those efforts. One other item that you will find at your seat is we have followed up on questions that came up during our previous meeting related to the epidemiology laboratory incapacity funding, and have had conversations with our budget team, legal counsel, as well as the state regarding the status of that funding, and we continue to follow up on that, but you will have a summary at your seat regarding what we know in terms of that funding and our efforts to help resolve some of the questions that came up about uncertainty around that funding. And that is the content that we had prepared for you today, and I thank the board for your time and interest in both the strategic plan and the TB program, and thank you for your willingness to join us in a work session related to budget.
All right, thank you, Deanne. And if there's no questions about that, our next and final item on the agenda is a closed executive session. And are you going to lead us into that, Lori, or is Nate going to come in?
I'll lead you into the executive session, and then I'm going to depart, and Nate will handle the executive session.
Okay.
So item 8 on your agenda is an executive session request pursuant to CRS sections 246402 4B and F for a conference with the county attorney's office for the purposes of receiving legal advice on specific legal questions pertaining to the recruitment and hiring of a public health director, and to discuss personnel matters concerning the recruitment and hiring of a public health director. In order to go into executive session, we do need a motion, a second, and then an affirmative vote of at least 2/3 of the members present.
Okay, so is there a motion to go into executive session?
Mayor Dixon, I'll move we go into the executive session for the reasons stated.
Thank you,
Second.
Mayor Dixon, and second from Commissioner Nelson. Thank you, Commissioner Nelson. I think we need to do a voice.
I would recommend
vote.
that, just to
Yeah.
confirm that we have the requisite number.
Do you mind doing that, Lori?
Not at all.
Okay.
Ms. Salt?
Aye.
Commissioner Geithner?
Aye.
Mayor Dixon?
Aye.
Dr. Chan?
Aye.
Mr. Donaldson?
Aye.
Commissioner
Nelson?
Nelson, thank
Aye.
you, sorry.
That's all right.
And I'm sorry, I don't remember your last name. Mr. Barnett?
Aye.
And then we-
Dr. Vu?
Mhm.
Aye.
Thank you.
Okay, so I think we need to take about 5-minute break while the staff prepares the room for executive session.